There we go. All right, I'll get right to it. So I'm going to talk about how we can use happiness metrics basically to value health. But before I'm diving into what that even means, I think it's necessary to kind of define happiness and what I will be referring to when I talk about happiness. So basically, happiness is this, you could call it, elastic suitcase concept that covers several dimensions. And the OECD guidelines on how you should measure happiness, they suggest that we should at least consider these three dimensions. So we talk about something called life evaluation, affect, and eudaimonia. These are interlinked and associated, but they are also rather separate concepts of well-being. Life evaluation is what we consider an evaluation of our life as a whole. Tomorrow and our experiences, daily experiences, but basically how we view our own life as a whole thing. Whereas the affective measure is more like the daily experiences, and then we have eudaimonia, Aristotle's conception of well-being, so to say, which targets more like flourishing and purpose. Today I will be referring to the first one, so life evaluation. This is the metric that is often used in research, and is the one that the World Happiness Report commissioned by the United Nations are basing all their happiness rankings on, like the rankings where Denmark and Norway and Finland and the Nordic countries are always like ranked as the happiest countries in the world. That's based on life evaluation. And a way to measure life evaluation is this way. It's called this Cantrell self-anchoring scale. So there's various ways to measure life evaluation, and this is like one of the most normal one, or most standardized one, where you basically ask people to rate and evaluate their own life from a 0 to 10 scale, 10 representing the best possible life you can live, and 0 the worst. In Denmark, we have an average of 7.4, which is one of the highest in the world. This is basically what these rankings are based on, and this is what I will be referring to today when I talk about well-being and happiness. So that's just to clear that out, because we will be talking about health. And health is also an umbrella concept that touches upon several dimensions, and it's not something we can define very narrowly. And when we do that, I think we are making a mistake. This is the definition by the WHO, which is one of the most referred to definitions of health, I think. But I also think it's one of the most accurate definitions of health, at least from the perspective of people and the experience of life. And I will get back to that. But the question here, and the question I would like to raise today, is whether these three dimensions that WHO touches upon, social well-being, physical well-being, and mental well-being, whether they are equally important for health, or whether one of them are more important, and how we should weigh them, because we don't really get an answer to that question here. But what I do argue, and what I do believe, is that our conventional way of measuring health and valuing health in health economics, there we tend to systematically emphasize physical health. And I'm not going to be religious about like alternatives here, but I just want to challenge that notion that that should be the most important one. It really depends on we build into the models we make, and that's basically what we're going to talk about today. So my argument is that the prevailing approach to value health, which is often done by what we call the health-related quality of life assessments, is not sufficiently mirroring how people and patients experience life. However, happiness research offers an alternative in valuing health for the purpose of showing what matters to people and ultimately for use in economic evaluation. So I'm going to use two cases now to support that argument. The first case is going to be like the case of general measures, the conventional way of measuring and valuing health in health economics, and the pitfalls of that approach. Then I'm going to use the case of psoriasis, this chronic disease, autoimmune disease that affects the skin, that is probably how most people are familiar with the disease, but it's a disease that I have studied for the last 3 years in relation to happiness. And I'm going to use these two cases to support that argument. So basically, yeah, the first case, the health-related quality of life assessments are widely used assessments in health economics and in evaluations, and it's also very widely used in public policy and in decision making. I think the intention of these measures are quite good, right? The intention is to show efficiency and how effective different health interventions and health technologies and even medicine are in terms of providing quality of life for the target group, the patient group. And common measures of health-related quality of life assessments include the EQ5D and the SF36 and different and variations of these measures. These are the measures that we use to inform what's called QALY, the Quality Adjusted Life Years. It doesn't. Many of you may be familiar with these measures, and I'm not going to go into a lot of details about them. But the QALYs are very important in public policy. In some countries, we are using them quite religiously to decide and to test the cost efficiency and cost effectiveness of different health interventions. In UK, they are very core and they're very decisive in terms of what is actually going to be implemented. Everything is going to be measured with the QALYs. Or in other countries, it has more an indirect effect, but they are at the core of health economics, applied health economics, and we cannot neglect their importance. Then there's also several disease-specific health-related quality of life assessments, such as DLQI, which is used in dermatology. So here's the question. I think we need to really consider which assumptions we are making when we are using and when we are applying these conventional measures. So this is the EQ5D. This is how it looks. This is what people are asked about when they are presented with the EQ5D and they are to evaluate the health-related quality of life. It's based on five dimensions. So it's mobility. I don't know if you can see that well, but it's mobility, self-care, usual activities, pain, discomfort, and anxiety and depression. And then there's 3 options of answers to each in terms of how severe they experience these different health factors. You could question, of course, whether these 5 factors are the most important ones. We need to include more, such as sleep and cognitive capacity, vitality, and there has been made attempts to expand what we are actually measuring. But let's leave that for now, because I don't think that's what's most important here. What I want to address is that I think this is an interesting measure, and I think when it's used to inform the QALY, we gain, and it's providing a lot of valuable and interesting information. But we need to look at how we actually gain that information. Because what we ask the general population to do after we have asked, so basically we ask people how they evaluate their life, and then we ask the general population to weigh these different health states. So it's not that we kind of accept that these 5 ones are not equally important, and we kind of need the general populations to weigh them, and that's part of the standard Gamble method, it's called, which we are used to then provide the QALYs. But the problem is that, or to say it in human language, basically that means we ask the general population what is most important, which one of these 5 factors are most important for your health. And that's good, because that's very patient-centric, a very people-centric approach. We are not just making assumptions on what should be most important. We are actually asking people. But the question is that the right thing to do? So here are the weights that the general population puts into the different factors. So what you see is that if you look at the red bars, we find that when we ask people what they believe is most detrimental to their well-being, which health factors are most detrimental to their well-being, they consistently say that it's pain and mobility issues. So we can then agree or conclude that pain and mobility are the most important factors for well-being. And if we then go back to the WHO definition of health, well, then we can argue that it's the physical dimension and not the mental and social dimension that are most important. But what if we apply another methodology? So in happiness research, what we want to do is we want to free people from making these assessments themselves. We don't want people to, it's a task actually to weigh up all these different factors. It requires a lot of cognitive capacity, and you have to simultaneously weigh up a lot of factors, and it's difficult, and it raises a lot of problems. So what we do is we actually just build a regression analysis. We ask people how they experience these different factors, and we test how that affects happiness. This is what we call experienced utility or experienced happiness, whereas the first one up here is what we call perceived happiness or perceived utility. So what happens when we build it on people's experiences, what's most important, rather than what they believe is most important? And it's completely different results. So basically, when we base our weights on what people experience rather than what they perceive to be important, mental health and usual activities turn out to be the most important factors. Furthermore, we find that if you look at the blue bar, that's the effect of happiness, and the red bar is the effect of, or the blue bar is how we experience pain, and the red bar is how we perceive pain, how important we perceive pain to be, then there's a huge discrepancy. We find pain, or this is like to quote Paul Dolan, the professor, in our imagination, pain has a lot of impact, but in our experience, it has less. And why do we find this discrepancy? Well, there's different theories to it. One theory is adaptation, the adaptation theory, which explains that there are several chronic conditions adapt to over time. But when you ask so this is what happens when you lose mobility, it's disastrous for your well-being, but only for a short while, and then you kind of adapt. You may not adapt fully, but your well-being levels turn up. You adapt to the condition. But people in the general population are not considering this. So that's a theory to explain the discrepancy. Another theory is focus illusion. So this is the theory of Daniel Kahneman, and Paul Dolan. So Daniel Kahneman, the Nobel Prize winner in economics, and he's a psychologist. But he have built a theory around focusing illusion and explaining how several physical part-time experiences that only affect well-being when attention is drawn to the limitation. So the way he explains it is like, try to imagine walking with a cane. So you have mobility issues and you have to walk with a cane. Well, that's a problem. That's an obstacle in life, and that does affect your well-being. I'm not trying to trivialize that problem, but it's only a problem when you draw your attention to it. There will be like several times of the day where you're not even considering this issue. But when we are asking you of whether it's you're making it a full-time problem because you are drawing your attention to it. This is not the case for mental health and social isolation to the same extent. Mental health problems are constantly a problem. It's a full-time problem. And that may be one of the reasons that we tend to exaggerate pain and underestimate mental health in these assessments. So, to sum it up, what we find, leading back to the WHO definition, and the question of which factors are most important for people, well, it depends on the assumption we are making and what we are building our health economic metrics upon. Are we building them upon to be important? Well, then physical functioning and pain are the most important factors. But if we build them upon what people experience to be most important and most detrimental to their well-being, then mental and social well-being turns out to be the most important factors. So the implication here is that mental health and social well-being matter more in happiness report, so one implication of using happiness to value health is that greater priority and resource allocation ultimately would be given to mental health and social well-being as compared to physical functioning and pain. So this is like the theory, and some empirical evidence to suggest that there's support for this theory. Thank you. Wow. But to support it further, we made research on a specific patient group. So I've been working on this for the last 2 years. We have conducted research, happiness research on people living with psoriasis. This is something we've done at the Happiness Research Institute together with Leo Innovation Lab for the last 3 years, last 2.5 years. And it's based on 80,000 psoriasis patients across 21 countries where we have representative samples. It's all collected online through apps and web-based surveys. And yes, we have a large sample, and we just basically asked a lot of questions about all the different dimensions of life to understand what is actually most important for this group of people living with this chronic disease. A way to show it is to actually apply the conventional measure again of health-related quality of life, specifically for psoriasis patients or people in the dermatology field. So when we are testing how much an health intervention for for dermatology can provide quality of life, we are using often the DLQI. But the DLQI makes some of the same problems as the other measures I just introduced to you, just in another way. The problem here is that we are all of a sudden just agreeing that these 10 factors are the most important ones, and we just give them equal weight. And then we make some score based on this. But we are not considering whether some of these factors may be much more important for the patient group. And we can test that by making the happiness regression again. So that's what we did. What we found is that for these people living with this skin condition, the two most important factors is whether they feel embarrassed and self-conscious, and whether their skin affected social activities. So we are seeing similar pattern here when we're looking at people with a chronic disease as we see in the general population. That it's mental and social well-being that are most effective and have the biggest impact on your well-being. Pain still have an impact. It has a moderate impact, how itchy, sore, and painful the skin has been. And some problems have a minor impact and some doesn't have an impact at all. It doesn't show significant impact on the patient group across all the countries where we have measured. So what does this tell us? Well, it tells us basically that there are a lot of problems we may not focus on because our health economic evaluations tend to focus towards physical functioning quite systematically, even though based on this scientific position, there may be something that's more important for people. So we asked these people living with psoriasis several questions also to get an idea of the magnitude of the social and mental health problems they are dealing with. What we find is that people living with psoriasis, they often experience social isolation. So we applied the UCLA loneliness scale, which is the most used scale to test social isolation and loneliness. And we find that between 19% of the population and 43% of the psoriasis population experience loneliness. We have a benchmark for the Danish general population, which means we can make a comparison. And we find that in Denmark, if you live with psoriasis, you are 6 times more likely to be lonely relative compared with the general population. That is if you live with psoriasis. So yeah, there's a huge social isolation problem related to this chronic condition, which is not sufficiently captured, is my argument, by our conventional measures. The same with stress. We're seeing extremely high stress levels when we apply the Cohen's perceived stress scale. Again, we have a benchmark for the general Danish population, which is about 30% of the Danish population who experience stress to some moderate to high extent. And it's twice as large for the Danish population for psoriasis patients. So you're twice as likely to experience moderate to high stress when you are living with psoriasis in Denmark. Finally, we have tested for the prevalence of different comorbidities when you live with this psoriasis. And what we find is that, back pain is the most prevalent comorbidity, and depression the second most prevalent comorbidity. So comorbid depression is the second most prevalent comorbidity among people living with psoriasis. 25% is quite similar to a general population study they did in UK, where they found that around 30% of all people living with chronic conditions suffer from a mental health problem. So we are finding similar numbers here. The interesting thing is when we put these into a regression analysis, we find that depression is by far the greatest predictor of unhappiness, and no wonder. So basically, the conclusion, so to say, is that for people with chronic diseases as psoriasis, social well-being and mental health seems to be the most important factors, and it's not sufficiently mirrored in the assessment, the conventional measures. But the question is it mirrored in healthcare, like in practice? What do people living with psoriasis experience in the practice, like when they meet with the healthcare professional? And what we find, so we basically ask them, like, how many of, like, whether they experience that the healthcare professional, like, recognize that psoriasis affects mental health, and this is the amount of people who say no. So around 50% across all countries experience that their healthcare professional doesn't really acknowledge it and doesn't really recognize this problem, which suggests that we still have, like, a separation of mental and physical health care, both like institutionally, culturally, and professionally, perhaps. The interesting thing is there's like some variations here between countries. Greece is doing relatively well compared to some of the other countries, and in our research we find that it may be due to the use of specialists in Greece, like dermatologists, which tend to be better at addressing these issues than GPs. So that's the hypothesis right now of why we see some variations. So what can we do? So we've been collaborating with a dermatologist who say, and I think this would apply to not only psoriasis, but several chronic conditions and chronic care. And he says that one of the most bothersome aspects of psoriasis as identified by these patients is that they perceive that healthcare professionals do not understand the impact of the disease. Reading this report can help physicians better understand the impact of psoriasis on patients' life. And more important than that, however, is not just to understand the impact, as many physicians already do, but to communicate to patients that physicians understands. Doing so may be the best, most immediate ways to reduce patients' distress, to encourage better adherence to treatment, and improve both their objective disease severity and their happiness. So, to sum it all up, basically, yeah, that's what some healthcare professionals may do, like an advice from Feldman. But there's also like a more political scope to this, if we are to address some of the social and mental problems related to especially chronic conditions. And if we really want to bridge the happiness gaps induced by chronic conditions, we ought perhaps to focus more attention to what we call experienced happiness instead of just perceived happiness. So looking towards happiness regressions rather than just looking at the conventional measures. So in the beginning of the next year, we're gonna publish a report. It's also based on psoriasis, but it's taking a more broad scope at chronic conditions, and it includes a lot of policy recommendations on what can be done to achieve like a more holistic approach to health and well-being. Thank you.